Ask it.
Ask it.
Ask it.
Ask it.
Ask it.
Welcome to the Ask It podcast. The Ask It podcast encourages talking about talking, facilitates your own inner wisdom, and rather than providing answers, considers good questions. Hi, I'm here today with John Hendon, who is a psychotherapist, a mental health consultant and a trainer, and he's based in the Southwest. And we're here today for today's Ask It question, which is, does the biomedical model of psychiatry really bring about lasting change for mental health issues? So, John, can you tell us a little bit about where you come from, how you arrived at being a therapist? What was your journey?
Yes, well, it goes back a long way, actually, Lucinda. I was one of the 1,000 or so unemployed psychology graduates in the early 1970s that went into the mental hospitals to change the world. And along with those, we tried to bring about change and influence things to move from an institution orientation to a more client-centered orientation. And gradually we had some successes, although many setbacks. And then I went down the mental health nursing training route, and then into management, and then was trained in 2 family therapy clinics, and eventually went into private practice, and I've been for 20 or so years. So in total, I've been in mental health and psychological services for nearly 45 years.
It's a long time.
It is a long time.
Okay. And so what's the current shape of your work at the moment?
Current shape of my work, mainly training. I've got 2 specialist interests. One is suicide prevention, and the other is severe trauma recovery. And I train people in 20 or so countries in both those topics. And I have a small practice in Taunton in Somerset, where I see people with a variety of conditions.
So what got you interested or questioning the biomedical model?
Yes, that's a good question. When I first went into mental health services, in order to survive, I learnt the biomedical model and practiced it within the teams. And then, like so many others, questioned it in terms of, did it help people? Did it make them worse? And the role of medication in all of this was highly questionable. People coming in with minor mental health concerns being sort of zombified, and lack of concentration, lack of focus, and they would say they're feeling they're getting worse as a result of the medication. So we really questioned what was going on there.
I know when I worked in a private mental health hospital, and I worked on the wards with young people, and there's one guy who particularly stands out in my memory, and he was a voice hearer.
Yes.
He had all sorts of intrusive, very tormenting, negative voices, and he was put on medication, as most of them would be. And I'd have a therapy session with him, and he could never bear to be in the room longer than 10 minutes. He was very, very agitated, and it seemed every time I went in and saw him, the medication had been increased and increased and increased, until such a point as he was like a walking zombie.
I know.
He was barely conscious, and yet the tormenting voices were still plaguing him. And then nothing had changed with that.
This is my biggest beef, Lucinda. Medication is masqueraded as treatment. It is not treatment. It's simply symptom masking. And yet the pharmaceutical industry, the companies that manufacture the psychotropic medication, they push this idea that it is treatment and that you've got some fault with your brain and this will correct it. It's been proved to be false, and it's well documented. People like the researcher Peter Gertcher the consultant psychiatrist, Joanna Moncrief, they've written about this extensively, yet why is it still happening? That's my question.
Okay, so one of the things I think that you were really concerned about was the idea that there might be premature deaths caused by overprescribing of meds.
Yes.
Yeah.
There's well-documented research to show that people on long-acting phenothiazines, people who've been diagnosed with schizophrenia, will live on average 20 years less than the normal population because of the harmful side effects of the medication and eventually the physical effects that result, like heart failure, etc., as a result of it.
And just so that our audience knows that we have researched this, and this just isn't about opinions. I've got a couple of references, and they'll all be on links put on at the end of the podcast. But Brian Miller was citing Tihonen and others who published in the Annual Journal of Psychiatry in 2016. They studied the relationship between cumulative antipsychotic, antidepressant and benzodiazepines exposure and mortality. And this study, what I liked about this study was it was significant size. There was over 21,000 people.
Yeah, big cohort.
All schizophrenic patients. And they found that overall medication did help all the patients rather than those patients that didn't have any meds. But the concern was taking meds in combination and also over a long period of time. And they identified that 74% were actually at a higher risk of death due to
74%?
Due to exposure.
Not aware of that
exposure.
paper. Yes.
Yeah. So Carell was another study. Benzodiazepines definitely come off worse. Antipsychotics and antidepressants weren't so bad. But one of the things that they identified in their study was that people that had existing physical diseases, it often aggravated those diseases.
I've heard that.
Or it brought out other physical diseases later in life that they may or may not have got. It seemed to exacerbate that.
Sure. And I've seen that with patients that I've seen in the community since discharge from hospitals many years later. So I can support that. Yeah. So
we're not looking at necessarily at how they're functioning now on this medication when it's reviewed. It's projecting, what is this doing in the long term? Is it shortening your life?
Yes.
Is it making you potentially at risk of something else? And that's a choice or a judgment that somebody can make for themselves. But they're not given that information in the first place.
They're not. And you mentioned the word review. Very interesting word that.
Right.
Often people aren't reviewed, or the review, in my experience over the years, there's been a quick review. Everything quiet? They ask the CPN, how are they doing at home? Oh yes, they're quiet at home and there don't seem to be any concerns. Okay, we'll keep the medication going. And that taps into what I call the AFAQL syndrome, which stands for anything for a quiet life.
Yes. And
psychiatrists practice this and general practitioners practice this. So a patient going to their practitioner saying, well, actually, doctor, I think I don't like the side effects. I'd rather reduce it, please. They get fobbed off because the practitioner doesn't want them to reduce medication because things are quiet, despite the quality of life or lack of quality of life. And some community mental health nurses do fall into this category as well, of practicing that.
Yeah, and what's that about? Why do people have to be quiet?
Exactly.
Who for?
Who for? For the system, for the service, isn't it? I think it's not for the patient or the client.
Well, and I wonder in hospital whether sometimes that's so that there's not a lot of trouble on the wards.
Yes, I've seen that.
I don't know. I can't prove that, but who are we wanting to keep them quiet for?
Yes, exactly. It's about control, really, not about quality of life or improving. And I've seen people who've taken their own. They've said to the GP, "Look, I really want to come off this now," and they've had their own reduction regimes, often too short, and they've suffered side effects. And I probably see about 2 clients a year and advise others on a reduction regime, because there's precious little information in the British National Formulary, which is the sort of the compendium of all the drugs, on how to reduce. If you look at withdrawal advice for anxiolytics, antidepressants, and antipsychotics, you'll find there's hardly any. At best, they say in withdrawal should be withdrawn over several weeks. Several? Is that 2, 3, 4, 5? Yeah. I find between something like 28 and 36 weeks for most psychotropic medication, that works. But GPs and psychiatrists, they don't know. They get no advice, so they make it up as they go along.
Well, there's 2 points there I want to pick up on, and one is I know from anecdotal evidence of my patients telling me that oftentimes they're just put on meds and it's never reviewed. And I say to them, well, has your doctor asked you to come back? When's that going to be checked up on? And they're just left on it for months, years at a time. Nothing changes.
Nothing changes. But it's quiet, you see. It's the quiet life.
Ticking along. And oftentimes, yes, I agree, when they've said, I want to come off, they said, well, give it a few more months.
That's right.
I'd like you to have another 6 months. For what purpose?
Yes.
What's the rationale?
Well, they're the fob-offs. Another is, remember the last time you reduced, remember you threw your tablets down the toilet and look what happened then? So I think let's have another chat in about 3 months. That's another typical conversation I hear from people I help reduce.
And we were talking earlier, weren't we, about Jordan Peterson, who a lot of people would have heard of.
Yes.
And I'm not sure, I couldn't remember how long he'd been on benzodiazepines. I got the impression that he hadn't been on them for that long, longer than you and I would think is okay, i.e. 2 weeks or a month out most. But he'd been on them for some period of time, and he found that his anxiety was getting much worse.
Yes, I found that with people.
Yeah.
Yes.
But any clinic in North America where he lives didn't have any other option for him, didn't have any other answer, and said it was too dangerous just to come off them. And in the end, his family found a clinic in Russia, I think it was, and he was literally put into induced coma for, I think it was 9 days, so that they could get him off them. And then he had this terrible experience with akathisia, I think I'm saying that correctly, and he described it as being prodded with a cattle prod every few seconds. So this terrible jolting happening. And when he said to them, look, how long is this going to go on for? Because he couldn't sleep, couldn't do anything. They said, well, it could be up to 2 years. And he said, you would kill yourself because nobody can survive that 2 days, let alone 2 years.
No. And Lucinda, I hear so many stories, sad stories. I was talking to someone yesterday whose close relative killed themselves because they couldn't stand the side effects any longer of this concoction that they were on. And it's so sad and it's so unnecessary.
Because that was the other thing that you were saying to me earlier, is that it's one thing doing a study on one medication, but there's very little research about how 2, 3, 4 might interact with each other.
And each individual pharmaceutical company has no responsibility to do any research on an interaction with another drug. I think they have something like 6 months they have to trial it for before it gets its license. and any side effects that occur within that trial or contraindications, they record on the data sheets. But beyond that, I don't think they have any responsibility. I may be wrong on that, I'm not sure, but I think that's that 6-month cut-off point.
And we were both saying that when we were in hospitals, working in hospitals in our different roles, a patient would be on one medication, it would be identified as not really helping them, or the patient would say, look, it's not really helping me, I've been on it 2 weeks. And then they'd stop that, put another one in place. And you were saying, well, maybe that first one's not even out of their system yet.
It's not. It gets stuck in the fatty tissue and is released slowly from the fatty tissue of the body. So the person, if they stop taking one and start another, they have the two in the system. And, we talk about medications, half-lives and things, and as well, it is a real problem. And, something you were talking about earlier reminds me of Professor Sami Tamimi, who is really on the ball in this field. And I'm pretty sure it was him who said, if the consensus is that psychotropic medication overall causes more harm than good, shouldn't we stop this practice and stop the harms being done? So there's him, there's Joanna Moncrief, another psychiatrist, there's Peter Goetsche, the Danish researcher, wrote a wonderful book cataloguing all that goes on, the tie-up between biomedical psychiatry and the pharmaceutical industry, although he included medicine generally. So there are all these people coming out with this research, and nothing happens. Nothing changes. And I was talking to a colleague of mine about this, and she has the same experience. She said, whenever I engage with biomedical psychiatry and suggest that we should think about change or think about change of practice, I get the same response. It's sort of a combination of being ignored or silence as a response, and nothing happens.
And I believe, like all of us professionals, we start out really, truthfully, really wanting to help people. We do.
That's why I came into it.
Yeah, absolutely.
Yes.
And so I don't want to criticise any other professional, because I'm sure their intentions at one point were good, but somehow the thinking gets distorted.
Yes.
And and I want to say at this point that I'm sure neither you or I, we are not putting the message out there, look, we're anti-meds, and that everyone should immediately, upon seeing this, drop all their medication.
No, it would not be a good idea.
Certainly not.
That's what we've just said.
But a little bit controversial, but one of my other areas of interest is the research. I think there's a research program being done in King's College, I think it is, Imperial College, with drugs that at the moment are still illegal. So psilocybin.
Yes.
I think there was
That's a magic mushroom.
That is the magic mushroom.
Yes.
And I think there was something done with LSD and this is a while back now. Yeah. And terminally ill patients.
Yes.
And who were terrified, obviously, of death. And they were given the LSD, or it may have been psilocybin. I will have to check that. And that they were so much more peaceful, so much calmer. The other thing everyone's talking a lot about at the moment is the ayahuasca ceremonies that were traditionally part of a tribal shamanic ritual. Yes. And the way it works is they mix two plants, and the resulting chemical is actually DMT. Yes. Which is found naturally in our brains, animals' brains, etc. And they found that was really useful. The ayahuasca was really useful for people that had chronic addictions. So they've been in therapy and trying to knock their addiction. They have one session, and somehow their
Yes.
mind gets into a different state where they're able to tackle it. And
Yes,
it's been very
sure.
helpful.
Yeah, I mean, I'd endorse that. I'm not. I don't want to give the impression I'm totally anti-medication.
No, not at
I mean, as a community mental health worker, I would get referred a whole variety of people in crisis, and it was quite common for me to recommend to the GP or the psychiatrist who'd give me the referral to prescribe perhaps an antipsychotic just for a short period of time, maybe
to get the mind able to do the
absolutely
therapy.
get access. And I remember one, it's easy to get anecdotal with this in this territory, but I remember one very hypermanic fella, and he had a family of 4, and he was almost at almost explosion point, and I recommended that he be prescribed a small dose of, again, it was an antipsychotic, just to bring him down to get access, and we tailed it off after 5 days, and that was fine. And again, with anxiolytics, sometimes just in a short space of time, but we're talking about a week or 2 weeks maximum, not these, as you mentioned, weeks, months, years, and decades sometimes, and the harm that's caused. And of course, with short-term medication, talking treatments running concurrently are really effective.
Both, yeah.
Yes,
yeah.
so both in tandem.
Yeah, I think there was a piece of research way back in the day I read where, loosely speaking, it was a third of people would get better on their own, just naturally.
Yes.
I think it was looking at depression.
Yeah.
A third got better with medication and talking therapies.
Yes. Mm-hmm.
And a third believed that the medication did help them.
Yeah.
But again, then we have to look at how much of that is the placebo effect.
Yes. Well, there's many papers on the placebo effects of antidepressants.
I've got one here. I'm not going to put my finger on it right now, but it will be in the links at the bottom, where an SSRI was being studied, and they found that in 80% of the patients, placebo effect accounted for feeling better.
Yes.
So that only left 20%.
Yes, I know.
Saying that the SSRI was making any difference. Well, and you're basing a whole medication on that.
I know. It's awful, really, and this is continuing. And so, my question was, how can we bring this to an end? It is, I think, it is an epidemic. It's at epidemic proportions in the UK and throughout the world. In the UK alone, the numbers of prescriptions of antidepressants has risen gradually over the last few years. And, my stage in my career, I've had lots of false dawns. I've gone to talks with some amazing mavericks and some innovators. I remember one, Dennis Scott, and he was a psychiatrist, actually working in London, I think it was. And he was talking about crisis intervention service, 24 hours. And he managed to close 4 wards in the local mental hospital. And I thought, this is the future. And things are going to change. But they change for a bit, and then it goes back to the status quo. Something seems to happen. And what a lot of other consultant psychiatrists who have been innovators, and I list loads, Ben Furman, Alistair MacDonald, Peter Breggin, etc., where services have improved. At conferences, they're cold-shouldered by their biomedical peers. Now, is that fair? These are innovators who are on the sides of clients who want to help them get better and have limited involvement with the system, and yet they get hooked in.
Yeah, and you and I have both had experience of that, where when you're working in that field, you feel you've got to be very careful about what you say, because you're not taken seriously at best, and and people are very hostile to you at worst. Yes. And I was only speaking to somebody the other day who was pulled aside by her boss in one trust and told, you must speak the party line, otherwise you are out.
I've heard that.
And
yes, many a time.
What upsets me is I am a very forward-thinking person. I'm open to whatever the latest research or new ideas are.
Yes.
I think, you know, that's what we have to do. And everything in me wants to provide whatever helps my patient.
Yes.
You know, it doesn't have to be about my ego or what I'm doing.
No,
or
sure.
just what is the best for my patient. And something else I've come across recently is a study on how ketamine helps with depression. So why aren't these drugs marketed?
Yes,
you know, why not? And these substances that I was talking about earlier, the ayahuasca ceremonies, etc., psilocybin, people have used these for years with no serious long-term side effects. So there are medications, if you want to call that, natural medicines,
yes,
that can help people. Why are we not researching and exploring those?
That's a very good question.
Why?
Why, yes. And there are various theories around that, and a lot of it is the terrific amount of money involved. I heard a figure, I'm not sure, this is probably out of date now, but the worldwide antidepressant market is worth $19 billion annually. So that is a big market, and the manufacturers of those antidepressants want to hold on to it. It's in their financial interests and their shareholders' interest to hold on to it.
But how many people have got to die for that?
How many people
become seriously ill?
How many people have got to die, and how many people have got to have their lives harmed? And Peter Gertcher, I mentioned earlier, he has calculated that 500,000 people die through psychotropic meds annually over 65 in America and Europe. And I have calculated, if you add in the under 65s and you look at deaths caused by suicide and homicide, which can be a byproduct of being prescribed antidepressants, road traffic crashes, other physical illnesses which occur as a result. If you add that in for the rest of the world, it's in excess of 1 million deaths a year. And so that we must bring that to an end, Lucinda. It cannot carry on.
And what I find very disturbing, because obviously here in the clinic we work with a lot of young people.
Yeah, sure.
And what I saw in hospital, the amount of medication young people are put on when their brains are still developing. They're not even fully developed until you're 24, 25.
No, they're not. And there is no evidence that,
well, we wanted to come to that point, because that's our next question that we're asking.
Don't let me jump the gun.
Yeah, where does this chemical imbalance in the brain theory come from? Because it's out there, public think that that's a thing, media promotes that that's a thing. I'll just get some more serotonin. Oh, that's your dopamine.
I'll correct it.
Yeah, you know, so...
It's been debunked. It's been totally debunked, and Joanna Moncrief, in her book in 2010, 2016, proved it. And yet, you probably have clients come through the door. I do. Well, I've got a chemical imbalance in my brain, and that's why I have to carry on with this tablet.
And they're convinced.
They're convinced.
And some even tell me they can feel it. They can feel this chemical imbalance being rectified.
Yeah. It's a myth. It has been demonstrated to be a myth.
And we should say where that arose from. My understanding is that this came out of a piece of research throughout the 1950s and 60s, and it was initially done on rabbits.
Yes.
And I think something that's not fully understood by people is the idea of correlation versus causation.
Yes.
So we could say that when you find depression, you find changes in serotonin.
Yeah.
And so then what's been assumed is that serotonin is therefore responsible for mood. So level of serotonin versus level of mood. But we can't say that causes that.
No.
It's like saying, well, when you turn get in the car and turn the keys, the engine comes on in the car. Therefore, it must be the keys that drive the car.
Oh, a good
Of course
analogy.
not.
Yes.
It's me that's driving the car. It's not the keys, but the car won't work without the keys. No. But the keys aren't the causing factor. It's me steering the car, driving the car.
Exactly. Changing the gears, etc.
Exactly.
Yes.
So this idea between it's semantics, isn't it? It's how things are said.
It is.
And then they're picked up on, and the false message is promoted.
It is, yes.
Yeah. And so one of the studies I read that was kind of proving that point was saying you could have somebody with depression and it's caused by either physical illness or it's reactive to some recent trauma, or it's an environment that's causing something, or it's even a brain injury that's causing
can
the
be
depression.
A traumatic brain injury. Yes.
Yeah. And they're seeing changes in serotonin with the depression.
Yes.
But clearly, if you take away the trauma, the stress, the injury, or the environment, the patient comes out of the depression. Yes. So it's nothing to do with serotonin.
Nothing to
you
do.
can keep somebody with that injury or within that environment, give them as much serotonin as you like.
Yeah.
Nothing's going to change.
Nothing's going to change.
Because the causative factor.
Exactly. And on that causative factor, now here's a thing. I remember going to a training day put on by Joe Griffin, and Joe Griffin and Ivan Terrell involved in the Human Givens organisation.
Yes,
they produced a book, and I think it was published in 2000. And Joe Griffin said in over 90% of cases, I think it's quite much higher than that actually, he said depression results from either unexpressed negative emotion and or undisclosed secrets from the past. And I thought about that. All the past hundreds and hundreds of patients, clients who had been diagnosed as depression, I thought they all fit in either A, B, or both together.
Absolutely. And
often I put that to clients in the room with me. I've said, there's this theory that when they said they've got depression, it's either undisclosed secrets from the past or unexpressed negative emotion or mixture of the two, which applies to you. And they look at me very seriously and said, the first one.
Yeah.
So I said, well, how can we talk about that that's helpful?
Yeah.
And then, surprise, their mood lifts over the weeks.
And you just think about the word depression. So what is being depressed or suppressed?
Yes.
And indeed, I will ask that question. And oftentimes, it's rage.
Yeah.
I find.
Yes. Unexpressed rage,
Unexpressed
perhaps.
rage.
Yes.
Yeah.
Yes.
But like you say, it could be secrets, could be anything. But it's being out of sorts with ourselves.
Yes.
And the other thing I wanted your ideas about is I found with people with recurring bouts of depression that's quite ongoing and quite chronic, I've found that there's a big sugar addiction.
Oh.
Have you come across that?
Interesting.
Yeah.
I've heard talk of this, yes. So they're sort of overdosing on sugary foods and sugary drinks, and it has an effect on mood.
Yes.
And they need another hit of sugar to...
Yes.
Yes, I've heard... I don't know too much about it, but I've heard it.
Yeah.
Yes.
So with the sugar, you get the initial high.
Yes, the rush.
But then it does terrible things to your body in all sorts of ways.
Yeah, it does.
But I'm interested in the links there, and I want to interview some nutritionists and naturopaths about what they think about that. But anecdotally, I find that mentioned again and again.
Going back to the D word, I remember having a conversation with Lucy Johnston, who's she's an amazing campaigner. And when I was a health service manager, and in fact I brought it along today, she published this book, Users and Abusers of Psychiatry. I think it came out in 1987-88. And I was a manager at the time in a large hospital and a huge community service. And I read this book and I thought, oh, we're doing that to people here. And this book was ignored largely by biomedical psychiatry, and they've carried on doing things. Anyway, Lucy, a psychologist, she worked in Bristol and Southwest. She's part of a group that came up with the Power Threat Meaning Framework, PTMF. A bit of a mouthful, but it's she puts it forward, she and her colleagues, as an alternative to medical diagnosis. And it's looking at threats in people's lives and symptoms they're having as having meaning for what's going on. Absolutely. Or what's happening in their lives.
And totally appropriate oftentimes.
Absolutely. And she said she was at a conference, medical conference, talking about this. And she said, so really, your non-evidence-based approach using medication, psychotropic medication, really you ought to put this aside and start considering an alternative approach. And she sat down and then hardly anyone moved a muscle. Just silence. But it's absolutely fundamental. And the reason for mentioning her related to the D word, she says, I don't like to use the D word because I think that's a medical term, biomedical term. She says, I'd much rather use really profoundly low mood. And that gets away from it. And so therefore we can talk about how can we raise your mood? Or tell me about a time when your mood was higher before.
Exactly.
I think it's a much better way of framing it, It's more healthy and respectful.
Yeah, instead of pathologising everything.
Instead of pathologising.
I was working with a patient yesterday and she was saying about these bouts of the D word she had. And when I wrote on the whiteboard the areas of her life and how much she would score them, and she could look at, how a lot of those weren't really coming up to the standard that she needed them to be. There was every reason why she wouldn't feel like getting out of bed in the morning.
Absolutely. Yeah.
So, and anybody in that circumstance would
be the same. They'd be hiding under the duvet as well.
Yeah, nothing to do with chemicals in the brain. No. It's just, not enough areas of my life are measuring up here.
Yeah. Absolutely, yes.
So, I don't know if we covered it, but I want to go back to it just to. So you like I have seen these things going on, but can you tell us a little bit about ultimately what we're here for, and what your campaign is,
right? And
why? Why you? Why now?
Oh yeah, I know. Why me?
You're the one with the hot potato.
My cross I bear. Well, as I say, I mentioned, I've seen so many innovations come and go in mental health services, and nothing changes overall. There are flashes in the pan, really. I've seen other approaches. I've seen big inquiries when there's been abuse in services, and you remember the Winterbourne View report inquiry when patients were cruelly treated. But in that same city 40 years earlier, there was a similar thing happening, and there was another inquiry, and the promise was that things would change and we would do things differently, but they didn't after a short period of time. There have been various approaches. There's been people have approached departments of mental health where there's been training of doctors to try and get the message across that there's different ways of doing things. And often those requests have been ignored or haven't been dealt with respectfully. There have been, on a heavier duty level, there have been pharmaceutical companies, and I won't name the products, there's about 3 main SSRI antidepressants which cause significant harm. And the manufacturers have been sued, but there's been out-of-court settlements with a non-disclosure agreement. Mm-hmm. So it suddenly all goes quiet, and the person's got the payout, and they're not allowed to say anything, which doesn't change anything for the good, for the service generally, and still 1 million people are dying as a result. There have been individual medical practitioners who have been sued for malpractice, and that's very hard to do. I mean, my job as a manager, I confess, was to parry some of these complainants and stop their case being pursued.
Or delay it so that people got worn out,
Fed up. That's right. You didn't reply to
hopeless
letters. That's right. And they eventually despaired because we had plenty of time. And then cases that did come were fought vigorously and often won, because the medical profession has 3 or 4 layers of tungsten protection. And but anyway, you know, again, there'd be an out of court settlement perhaps, and non-disclosure agreement. So again, nothing changes. So what I thought was that maybe, and I've been struck by the class actions for the earlier ones with asbestosis and can't pronounce it, is it mesothelioma or whatever it is, in the 60s and 70s, the class action, more recent one with the postmasters and postmistresses who, with that computer failure, who some of them went to prison because of the computer system showed that they'd falsified their accounts.
Oh. And
they had a payout earlier this year, and it was a class action. But the most significant of all in recent memory is the Hillsborough disaster.
Yes.
And, you know, all those relatives of their sadly deceased football fans, eventually they got the inquest overturned, and their class action got them a great victory. So what I'm hoping is that a class action this time against an employer of 1 or 2 egregious practitioners of the biomedical arts. So those who insist that treatment is psychotropic medication, and they largely ignore effective talking treatments that you and I know about and practice weekly. So that a class action against an employer with maximum publicity during the case and after, with no out-of-court settlement, no non-disclosure. So we have a good media advisor to advise every step. So I produced this paper. I mean, it was 2 pages to start with. I just, you know, how you start things out on the back of an envelope, think, this is a good idea. Anyway, 5 drafts, and 16 pages later, I had this huge document. So I circulated amongst friends and colleagues, home and abroad. And I've had overwhelming support. Good luck with this one, you know, fantastic. Something needs to happen. We must bring about change. Anyway, this has gone to various quarters. There's been various patient organisations and advocacy organisations, lived experience groups who want me to write an article on abbreviated form for their journal or online journal. And I've had individuals who've got their own cases ongoing, and I've heard one in the last 3 months where they've actually got the health authority or the mental health partnership trust to admit liability for the death of their relative. Unheard of. Everyone was gobsmacked, including the legal firm that took on the case. So it may be, Lucinda, that we may get a class action, but it might be individual actions that get a result. My hope and prayer as this goes on is that one by one you'll see partnership trusts saying to themselves, we've got to be careful here. We've got to check on who we recruit and what their practices are. And maybe we need to look at the practices of the staff we employ, the practitioners, and so we don't want to be liable. So my hope is that there'll be incremental change. But wouldn't it be wonderful if there was a major class action with an outcome a bit like the Hillsborough payouts and disaster?
But look how long they had to wait.
They had to wait over 25 years, yes. And Lucinda, I'm prepared, and I said in the document, I'm prepared for 7 to 10 years for this. And won't that be worth it if at the end, this practice is discontinued, of prescribing psychotropic medication masquerading as treatment if lives are saved and the quality of lives of those who are condemned to take this medication for many months and years, they actually are able to get their lives back.
Because the sad reality is, we were talking about this earlier, you and I and our colleagues are sitting in a room with somebody who's absolutely suffering in daily torment, minute to minute to minute.
I know.
Absolutely tormented in one way or another. We're seeing that day in and day out.
We are.
And as we said, we're not anti-medication, but often what we were talking about earlier, which upsets me, is that you and I both work in private practice,
yes,
and so the people we see are able to fund themselves their treatment, but the people that are what we call the revolving door patients, because they're not getting the right treatment, that are in the trust care, they go round and round and round.
Absolutely.
They have no resources, financial resources to pay for any alternative service.
No.
And so they're often the ones that most need it, because they're very unwell.
They are, and they've had severe trauma they've experienced either in childhood or in adulthood, which is unaddressed.
Yeah, and so the people that are really, really suffering the most, who need the most help, are getting the worst kind of care.
Yes, I agree. I've seen it for so long. And, not only am I not anti-medication, I'm not anti the NHS. I mean, throughout the COVID-19 pandemic, the amount of public affection towards the health service and all the health service staff and the teams, it's palpable, isn't it?
Well, look, if I broke my arm right now, I'd go to the
Absolutely,
hospital
I would.
straight away.
Yes.
But if I had a chronic ongoing mental health issue, I probably wouldn't.
No, and the biomedical model is very appropriate for the broken arm.
Of course it is.
But it's not
and I'd want all the painkillers that go with it. Thank you very much.
Thank you very much. Yes, while the pain's there. But for things with the head, the mind, it's totally inappropriate. And, if a class action or any action achieves a payout of several £1 million from an NHS partnership trust, we could be doing the NHS, the mental health services generally, a favour. Because if it changes practice and they say, right, no more medication, no more, willy-nilly, free-flowing prescribing of psychotropic medication to everyone who comes into the mental health service, the savings on the drugs budget would go into tens of millions. You work that out across the country and across the world. That money could be reinvested into better services. So, okay, they may take a few hits of a few £1 million compensation for lost relatives and harmed individuals, but they would benefit in the long term from increased funding.
And I think one of my messages is to get people to not be frightened to ask questions, to think critically about things. I know it's hard when you're the one suffering, but maybe you've got a friend, a family member, an advocate who can ask those questions for you, do that thinking for you. If something doesn't feel right for you, it's absolutely okay that you should ask questions about that.
And not be criticised for doing so.
Exactly. Exactly my message.
Because there was something came out a while ago about collaborative care packages, and it's, this is going back 20 years, I think, that a care package for an individual client coming out of an inpatient facility, it would be collaborative, so the team would ask what the patient or client wanted to happen, and they'd both sign off the plan. I'm sure that was, round the turn of the century, even before, maybe even the 1990s, that was happening. So that supports that idea, doesn't it?
Yeah.
Ask questions.
Yeah.
It's my
body, my
head.
mind.
Yeah.
I know how I feel.
Exactly.
You don't know how I feel unless I
Yes.
explain it to you.
Exactly.
And often words are limiting. They can't express.
Mm-hmm.
You know, it's hard to put feelings into words.
Yeah.
Because they can be intangible.
Mm-hmm.
But yeah, exactly that you are the expert. We as therapists talk about the patient being the expert on them, and yet we come up against the doctor or the consultant or whoever, and suddenly we give all our power away to them.
I know.
And don't take any responsibility or action for our own care.
I know, that's right. And there's this mystique, and I mean, I was very much aware of this when I worked on inpatient units and wards, etc. You know, the person comes into hospital in a distressed state, to be sure. They get assessed and they end up with a diagnostic label.
Yeah.
And then the treatment is medication. Take this 3 times a day, take this twice a day, and take this at night. And then it all goes quiet, you know, and you might ask the question, well, what's happening now? Oh, well, we're observing. What are we observing? We're observing change. We're observing how the medication's working or not, and whether it needs tweaking. But if you say, well, hang on, medication is symptom masking or symptom alleviation. It's not treatment. Isn't treatment talking treatment? So shouldn't we be talking to people? And I used to get funny looks.
I've had people, loads of different diagnoses over time.
Yeah.
And you think, well, they must have been in and out of therapy. And you say, well, what therapy have you had? Nothing.
Nothing, I know.
And even being an inpatient, having no therapy.
No, I know.
Nothing. No other intervention.
No other intervention. It's appalling. And we know that talking treatments, effective talking treatments, get people's lives back. And I remember, you just reminded me of, I had a fellow who, he was on inpatient unit, and he was diagnosed as a chronic depressive. And he was told by 2 biomedical consultants over a period of a year that he had got a profound fault with his brain, hence the diagnosis, chronic depression. And the best thing he could do is to take the medication and exist, or eke his years out as best he could. Do you know, in the first session, Lucinda, I spent 2/3 of the session deconstructing chronic depression.
Yeah.
And I talked about Joe Griffin's ideas. I mentioned about unexpressed negative emotion. I could see why he was feeling so absolutely low because of an employment thing that had never been resolved. Anyway, cut a long story short, he phased out the medication over the 7 sessions I saw him, which was about 5 months. Had a ceremonial bonfire in the garden with the armchair he used to sit in, staring out the window each day. And he got accepted on temporary work. It was a short-term contract working in a local government office with a promise that after a probationary period he could apply full-time.
Beautiful.
Isn't that wonderful?
How fantastic.
And if only that could happen to the tens of thousands of others who are sat in their armchairs staring out the window at this moment in the UK alone. One
of my supervisees brought a patient she's working with, was diagnosed 25 years ago with schizophrenic. Never been reviewed since. Lived her whole life with this label of being a schizophrenic. And of course, family and friends buy into that. Oh, well, of course, you know.
You can make allowances.
And have you taken your meds today?
Yeah, I know. And, there's so many stories like that.
It's okay, maybe she might have had an episode of something or what something was going on to be given that diagnosis. But I don't hear, and it's not for me to diagnose, but I don't hear of or see anything that supports that diagnosis now. And she feels her whole life has been stolen from her.
Yes,
because she's been living under this idea that, well, I've got that, so I can't engage with life, or I won't be able to do that.
Yes.
So it's kind of learned helplessness because of a diagnosis.
Yes, it is.
And again, I will clarify and say that for a lot of people, diagnosis is really important to them.
Yeah.
A lot of our patients
Yes.
really do want that, don't
Yes,
they? Others don't.
They want to hold on to it.
But they
Yes.
do want to have.
Thankfully, it's
that.
a small minority, and I've found even with that minority, they are open to the idea of other ways of looking at things. And I and other colleagues talk about, I forget the technical jargon, but the layman's language is nibbling around the edges of a fixed belief.
Yes, yeah, because we can't drag that
No,
away.
you can't. That's the
terrible.
whole idea. Yeah.
So we've been talking a lot about what we don't want to see.
Yes, plenty of that.
What we don't think is helpful.
Yes.
So we need to talk about, well, if we take this away, what are we going to introduce instead?
Yes, absolutely. And increasingly, and besides CBT, there are loads of effective talking treatments. And I'd like to see them brought in onto main stage in this process. And sometimes people say, oh, yeah, it's all right, talking treatments are all well and good for anxiety and depression, or avoiding the D word, extremely low mood. But what about psychotic states? What about schizophrenia? But it's amazing, the research that has been done in Finland and has been replicated a bit here in the UK, and services have been set up here in the UK on this basis. And my Finnish is not up to scratch entirely, but it's Jaakko Sekkola, and surname spelled Seikkula. And he set up a service, this is going back 20 odd years ago, which was a crisis family intervention service, and I forget the exact name of the study or the title of his service, but what he did was, once someone, maybe a late teens, early 20s, had been diagnosed or showing psychotic symptoms, the team would go into the home and give family support, and they may prescribe medication in the short term. But they found that by supporting the individual, supporting the family, they had amazing outcomes. And they did the first study, there've been several studies actually, with him and other team colleagues. They found that after 5 years, and the figures here, you have to check these out, something like 81% were in full-time employment, 81 or 82% did not have symptoms, and 15%-ish were on medication. That's
phenomenal.
Phenomenal. And, what amazing results. And it was a properly peer-reviewed piece of research. And, this should be mainstream. But it's ignored by biomedical psychiatry and the pharmaceutical industry, who want to keep prescribing antipsychotics. And I mentioned $19 billion industry worldwide in antidepressants. Goodness knows what it is with antipsychotics as well. And
it's such an old-fashioned view of schizophrenia anyway, isn't it? The idea of psychosis, etc. And, where I'd like psychosis to be changed into life crisis.
Life crisis,
because a lot of it is cultural, isn't it?
Yes.
So the idea, because if you were in a more tribal society, and you had an episode of psychosis, you were considered really fortunate because the spirits had chosen you
to
be a
that.
shaman.
Yes, I remember those. Yes,
and so it's a cultural view. And because I did, as I was saying to you earlier, I did my dissertation on voice hearers. In the Netherlands, you had Rom back in the 80s, who began to ask patients what their voices meant for them. And to make meaning out of this.
Yes, make meaning.
Because this is happening for some reason.
Yes.
So rather than just saying, oh no, it's because your brain's wiring's gone all wrong.
Which goes back to Lucy Johnston's work, Power Threat Meaning Framework.
Exactly.
All symptoms have meaning and all expressions have meaning.
Why is this happening now?
Yes, exactly.
And you might need something to moderate that because it's not manageable.
For
the short term.
Yes.
But oftentimes, as we were saying earlier, when you look at somebody's situation, you can see that it's a very legitimate response to something that's completely unmanageable.
Absolutely.
So I would even like that term changed.
I would. I agree. Again, it's a heavy duty.
Come away from this pathologising.
Absolutely, it's a heavy duty biomedical term. Another one of my beefs is PTSD. Again, that's a heavy duty biomedical term, and it condemns people. Yeah, so we need to change that.
Yeah, and you mentioned PTSD, post-traumatic stress disorder, and the way trauma is dealt with by medication, and this idea, and it's becoming more mainstream now. We know how the body gets impacted with trauma, and in our fields that's being discussed more and more and more. But this idea of one of the things that the body naturally wants to do after trauma is to shake. Like really, really shake. And we know how useful that can be in releasing stuff from the body. And yet you go to hospital, they'll give you something to stop you shaking.
I know they will.
So the natural mechanism that the body knows how to do.
It's deprived of.
It's deprived of.
Yes.
So in our conversation, we've been talking about how these memes, these stories, these half-truths get promoted, in popular culture and in popular media. But you wanted to ask a question about how might the media actually help us rather than promote these false
and I think
ideas.
I'd love to see that. I'd love to see a change. There was a newspaper I read, just a sort of side story, and they constantly talked about mental health issues in very pathologizing terms. And it seemed that they'd obviously on their team had got someone who was really rooted in biomedical psychiatry. And I wrote about it. I saw, after several articles over several years, I was appalled at this because it wasn't very honouring for clients and patients that we see. So I wrote about it, and they've completely changed. They've obviously got someone else who talks about mental health issues as being things we all experience, and we can all be empowered to take action and deal with it and have help from others, professionals. And I'd like to see a similar shift in the mainstream media. They made a shift a few years ago when they were warned that if you report dramatic suicides, it increases the suicide rate over the next week or so. It doesn't reduce it because they sensationalize suicide. So the media generally have behaved since that time, and they've said someone died, cause undisclosed or whatever. So they can make a shift with that, with reporting suicides. So perhaps they can make a shift with this area and actually reporting what works in mental health services and what's best, rather than parroting the pharmaceutical industry line and the biomedical psychiatry line. They need to have a real sea change, I think.
And we were talking, weren't we, about hopefully we can get a journalist to get interested in
I'd
this
love
subject.
that to be, yes, to really get interested, steeped in it, and be, a key reporter, perhaps, of what we're trying to develop, improvements we're trying to make.
Yeah. So as always, with our Ask It questions, we end up having far more questions than we ever do answers, but that's not the point. We are here just to ask questions.
Yes, sure.
And so my final question to you for today is, tell people what you're doing now, aside from all of this, if you have any other time, what you're doing, how people can contact you if they want to.
Yes. Yeah, sure. They can contact me through the website, which is 3Ws johnhendonconsultancy.co.uk.
Okay, and again, we'll put a link
onto that. What am I involved in at the moment? Well, I've been, as I mentioned earlier, I've specialised in solution-focused suicide prevention over the last 2 years, and have been assisting promoting zero suicide in all the teams I train. But the other arm is I've been working with survivors of severe trauma over many years as well. And a colleague of mine and a mentor really is Yvonne Dolan in America. Lovely lady, like me, a survivor of severe and enduring childhood abuse and neglect and adult trauma. And she came up with the idea that we're one time a victim, then we're a survivor, but there's a third stage, a thriver stage, that we can actually thrive despite trauma. And so what I'm working on at the moment, I mean, that's what I teach, how to thrive after trauma. But I've actually developed a questionnaire, and it's a 36 question questionnaire on thriving. So it's the Thriver questionnaire. So people who've come through trauma, they've survived and they're now living their life to the full. They can fill in this questionnaire. There's a 10-point scale on each of the 36 questions to see how well they're doing.
Brilliant idea.
And I've got accompanying it is a 3-pager just saying what thriving is about, for them to get a real idea of what it means to thrive.
Yeah. And you get a good response from that?
It's my latest project. So I've just started it.
Right, okay.
And I've just submitted an article for the Australasian Association for Solution-Focused Brief Therapy Journal, which has recently been renamed. So I'm hoping it would be published.
And what I like about that, completely in line with solution-focused thinking, is you reorient the brain from what's wrong
absolutely
to what can be right here.
Yeah, what can be right and what's working.
And even if it's only a millimetre, how you're stepping forward.
Yeah.
And it just completely reorients that mindset, doesn't it?
Does.
Yeah.
And behaviour changes as a result.
As a result, absolutely. Okay, so thank you so much for joining us today.
My pleasure. Yes,
really
thank you.
Great.
It's been great to talk to you.
And good luck.
Thank you.
Okay.